person climbs to a high altitude, what happens is the composition of the air will remain the same. That is the fractional composition or the percentage. It will not change. But the partial pressures of all the constituents will fall because the total barometric pressure will fall. And you learned about the relationship of the total barometric pressure and the partial pressures during your lecture that was dedicated for partial pressure. So as a result, what happens is the partial pressure of oxygen in the inspired air will fall. So this is the main challenge when somebody climbs to a high altitude. It is this reduction in the partial pressure of oxygen in the inspired air. Okay. So as a result of this hypoxia, when the partial pressure of inspired air falls, naturally the partial pressure of alveolar oxygen also falls, and partial pressure of arterial oxygen also falls, if you can remember the oxygen cascade. So now acclimatization means the initial change, it is divided into initial changes and late changes, and it refers to the way an individual will develop tolerance to this altitude. So another word for this acclimatization is altitude tolerance. So what will happen? One main thing would be, as soon as somebody climbs to a higher elevation would be the reduction in the partial pressure of arterial oxygen, which is also called hypoxemia. And you learned respiratory regulation. And when there is hypoxemia below a certain critical level, there will be stimulation of respiration and the person will start hyperventilating. And when the person starts hyperventilating, what happens is the partial pressure of oxygen does not increase so much, but there will be very significant reduction in the partial pressure of carbon dioxide, which is leading to hypocapnia. And again, if I can go back to regulation, you will remember that hypocapnia will inhibit respiration, and therefore this hyperventilation, it happens initially, but then again the progression of hyperventilation will be limited or restricted due to this hypocapnia. So when the carbon dioxide level is low in the arterial blood, that leads to a change called respiratory alkalosis. And and there's another thing that happens in the cellular levels. There will be increased 2,3 DPG levels. And as you know, if you can remember the oxygen hemoglobin dissociation curve, respiratory alkalosis will try to pull it towards the left side. But when there is an increase in the 2,3 DPG levels in the red cells, that will try to pull it to the right side. And the net effect of these opposing effects would be a small shift in the oxygen hemoglobin dissociation curve to the right side, which refers to an increase in the P50 of the oxygen hemoglobin dissociation curve. So therefore, there's a slight advantage here for oxygen unloading in the initial stage during acclimatization. So then these things that I already spoke to you will happen during the initial 24 hours life. And after the first day, then things will further change. And these are called delayed changes. So earlier I said that this hyperventilation and increase in alveolar oxygenation and alveolar ventilation is limited by respiratory alkalosis. In order to counter that, there will be active transport of hydrogen ions into the cerebrospinal fluid, and this will again stimulate the respiratory chemoreceptors in the brain, and that will now increase the ventilatory response. So the initial limitation or initial restriction of ventilation is now counteracted by these hydrogen ions that are transported to the cerebrospinal fluid. And the ventilation now will progressively increase in response to hypoxia. And there was a respiratory alkalosis initially. In order to counter that, there will be renal excretion of bicarbonate. So the body will start getting rid of bicarbonate through the urine by the second day. And another thing that happens due to hypoxia would be hypoxic pulmonary vasoconstriction. But this is not a good thing because it increases the pulmonary vascular pressure and it increases the workload of the right heart. But you can't help it. These pulmonary vessels, they have this inherent property of responding to either local or systemic hypoxia, and as a result, they will constrict. So hypoxic pulmonary vasoconstriction also occurs. And then once the initial period is over, there will be increased erythropoietin secretion also, and the red cells will start producing at a higher rate, and that will lead to polycythemia. And at the cellular levels and the tissue levels, also the number of mitochondria, the number of capillaries, and the content of cytochrome oxidase in mitochondria, and the content of myoglobin, which is another oxygen-binding protein in the muscles, which is like somewhat similar to hemoglobin, but it is not. So the content of myoglobin also increases at the tissue and the cellular level. So all these are delayed changes. They are categorized under delayed changes during acclimatization onto high altitudes. Right. So do you have any questions up to that point? Right. So let us move on to another challenge that the body is sometimes faced with increased barometric pressure. And the example that we take in order to explain the changes in the respiratory system is deep diving. So deep diving presents a number of challenges to the respiratory system and other systems in the body, but we are focusing on the respiratory system. And most of these challenges are associated with the external hydrostatic pressure that the body has to bear at an increased depth in the water. So as you descend to greater depths of water, because water is denser than air, the pressure quickly rises as you go deep and deep beneath the surface. So for a column of water which is about 10 meters high, a pressure is exerted what is equivalent to that of 1 atmosphere, that is about 760 millimeters mercury. So a diver at about 30 meters underwater is subject to pressure approximating about 4 atmosphere. And this causes a reduction in the alveolar volume and an increase in the partial pressure of all the gases in the body, because the water compresses a diver from all sides. And this poses 2 significant challenges to the respiratory system. What are they? One is the partial pressures of gases in the blood will now increase because the gases will now dissolve in blood. and also the volume of the gases will decrease with increase in the pressure. So what are the gases that are of concern to us during this situation? So there was something that we didn't talk about much during our lectures. We were focusing on oxygen and carbon dioxide, but during this increased barometric pressure situation, during deep diving, this gas, nitrogen, which is present in a very high fraction in the inspired air, becomes significant. So there is nitrogen and at a percentage of 78% and oxygen 21%. And when a person dives below 40 meters, the partial pressure of nitrogen rises in the blood to a point that it dissolves in tissues and it disrupts the functions of ion channels. And therefore, it is said to have an effect like ethanol, where the person might, feel a sense of well-being, but it can, later on, it can cause confusion and sometimes even loss of consciousness. So then there's another problem during deep diving, which is called decompression sickness, actually, which happens when the diver ascends from the depth to the surface. So now during diving in the depths, the nitrogen was dissolved in certain tissues. And because nitrogen is an extremely lipid-soluble gas, it dissolves in tissues where the amount of lipid is high, like in the nervous system, in the bone marrow, and fat. And if this person ascends now rapidly, very fast, this partial pressure of nitrogen in these tissues will reduce now abruptly, and the nitrogen will come out as bubbles, causing air bubbles, and it boils out of tissue. And these air bubbles can block blood vessels, and it can lead to ischemia, sometimes ischemia in the spinal cord, leading to paraplegia or paraparesis. And if it happens in the joints and the muscles, and these people get severe pains, which are called bends because they bend in pain. And if it happens in the lungs, it can cause pulmonary embolism and it can give rise to breathlessness, which is called chokes. So this condition is called bends and chokes, and this happens if the person ascends to the surface of the water rapidly. And also because the oxygen also dissolved in increased amounts in the tissues, that can give rise to neurological defects in the body. Right. So that was something about diving, and now this is to a greater extent has been mitigated by use of proper diving apparatus nowadays. But still, there are divers in certain areas in Sri Lanka who dive without any kind of protective equipment, and it can this decompression sickness and nitrogen narcosis still happens rarely. And what you need to do is if the decompression sickness happens, you need to increase the environmental pressure once again very quickly in order to stop this nitrogen from boiling out of tissue. And you have to reduce the pressure inside a pressure chamber very, very gradually, so that nitrogen will come out very gradually. And this type of decompression chambers are available only in one place in Sri Lanka, that is at the naval base in Trincomalee. It isn't available in any other place in Sri Lanka. So that is just a little bit out of physiology, but of interest maybe to some of you. Right. so that was about the environmental challenges, a fall in the barometric pressure and a rise in the barometric pressure and what it does to the respiratory system. And we will now look at two other situations where there would be physiological changes in the body. One is aging. So even if you age healthily, there would be changes in the respiratory system. So one such change is both anatomical and physiological dead space are increased. So this increase in the anatomical dead space is thought to be due to dilatation of bronchi that happens with aging. And because the effective surface area for gas exchange is reduced, the diffusing capacity is reduced. And there's a small increase in the lung compliance also, as I told you in the compliance lecture. Increase in the compliance also sometimes not very good. So this increase in the compliance is most of the time due to loss of elastic tissue from the lungs. And the respiratory muscle strength is diminished with aging, and as a result, the lung volumes and the capacities are reduced. And the functional residual capacity and the residual volume are increased, and the vital capacity is reduced while the total lung capacity remains unchanged in these people. And also their regulatory responses to hypoxia and hypercapnia are diminished due to aging. So those are some of the respiratory responses to aging. And there's another condition where there are certain respiratory adjustments, that is pregnancy. And in pregnancy, most of these changes are due to progesterone, increased progesterone, and as a result, the oxygen consumption is increased, and it causes, actually very clearly, how this progesterone causes an increase in the tidal volume is not very clear. Probably it affects the regulatory mechanisms. So the tidal volume is increased while the breathing frequency remains more or less the same. So the pregnant woman will inhale and exhale a higher volume of air, and as a result, the respiratory minute ventilation would be increased, and the partial pressure of arterial oxygen will increase, and the partial pressure of carbon dioxide will decrease as a result of this increase in minute ventilation. And also there are certain changes due to the enlarging uterus. So while these progesterone mediated changes are due to the chemical changes in the body, the enlarging uterus causes some mechanical changes as well. So the abdominal dimensions and the rib cage dimensions increase, and this would cause some increase in the inspiratory capacity, and also because the diaphragm descends a little upwards, diaphragm ascends a little upward, some of the lung volumes and lung capacities, like the functional residual capacity and the expiratory reserve volume, those are reduced. So these are some of the changes during pregnancy, which is due to progesterone and the enlarging uterus. Right. So now, before we go on to the next section, we'll do a small picture quiz, and please take 30 seconds per question. I will move the slides after 30 seconds. And of the questions that I'm giving, only one option is correct. So you can send the answers in the chat feature. So please send the answers so that I know that you all are doing. Otherwise, I will have to wait here, not knowing what you are doing. Just let me go to the stopwatch. Right. Okay, I'll be moving the slides every 30 seconds, okay? Next question. Next question. Okay. Next question. Next question. Okay. So, thank you. I can see responses coming. So I will just wait for a few more seconds and I will go back to the questions. Right. Okay, here. So the question was 5 stages of an alveolus during a breathing cycle is shown from 1 to 5. In which stages is the surfactant concentration is highest per unit alveolar surface area, stages 2 to 3 or stages 4 to 5. So the correct answer there would be stages 4 to 5. I saw that a lot of you had answered correctly. Only a few had answered, given the wrong answer. So it happens because during the expiration, the alveoli become smaller, and as a result, the surfactant concentration increases per unit alveolar surface area. The significance is because the surfactant concentration increases, the surface tension is mitigated or reduced to a greater extent, and as a result, alveolar collapse during expiration is prevented. So that's the answer and the explanation for that. And here, in which region is the airway resistance highest in a healthy adult? Zone A or zone B? So zone A is the conducting zone and zone B is the respiratory zone. So in a healthy adult, the airway resistance would be highest in within zone A, not in zone B. Although airways are much smaller in diameter during zone B, I think I told you in the lecture on airway dynamics why the resistance is less in zone B. That is because of this parallel arrangement of the airways and because of the huge total cross-sectional area of the airways. In a healthy person, the resistance in zone B is much lower, and most of the resistance in the respiratory system in the airways are offered by airways in zone A in a healthy person. But if somebody gets a disease in very small airways, then the situation will change. Okay, here also I saw that most of you had given the right answer, but some of you had mixed up also. So here, what you see is a normal person and the tracing from a person with a restrictive lung disease like in pulmonary fibrosis. I told you if you were to remember one example, just remember pulmonary fibrosis, generalized pulmonary fibrosis, where the lungs will be very small. And the key to identification of this pattern is the shape is the same as the normal graph, but the the forced vital capacity is very much reduced. And in comparison to that, FEV1 is okay. So if you look at this graph, so this is that of a restrictive lung disease, the pattern. Obstructive lung disease is different. It's more or less a linear graph that you will see in obstructive disease. So here again, an important concept in respiratory physiology, alveolar shunt, whether it is diagram A or diagram B. So it is diagram A, a shunt refers to a situation where deoxygenated blood coming to perfuse an alveolus is returning to the systemic circulation without getting oxygenated. So this is the A is the diagram which represents the alveolar shunt. Anyone knows what the other one is called? Diagram B? There's a name for that. Anybody would like to answer?
Physiological dead space.
Alveolar dead space.
Very good. Alveolar dead space. So alveolar dead space contributes to physiological dead space, but physiological dead space is the sum of anatomical and alveolar dead space. Thank you. It's nice when you answer. Otherwise, it's like me speaking to a blank wall. So thank you for those who answered. Just give me a moment. Okay. Right. So this again, most of you gave the correct answer. lot of you, although you may not have heard about these other tests, peak flowmetry, you all got to know about spirometry during the lung volumes, capacities, and lung function tests. So it is spirometry that gives you the information whether a respiratory disease has a restrictive pattern or an obstructive pattern. So, like even in the picture itself, you can see that pattern here, right, on the screen. Okay. So, but peak flowmetry, it helps you to assess whether your airflow rate is normal or not, but it will not give you any idea as to whether the respiratory disease that person is suffering from is obstructive or restrictive. Any questions there? Okay, thank you. Right, so we will go to the next part then, respiratory adjustments during disease. So respiratory adjustments or responses during disease are largely due to the development of hypoxia. And hypoxia is defined as oxygen deficiency at tissue level. So the respiratory system will try to overcome or compensate for hypoxia by its responses. These are the types of hypoxia. There are 4 main types. Now, students, please pay attention to this. This is something that you have to know in and out about hypoxias. The 4 types, you need to know the definitions. You need to know at least one example for each of these types. So, hypoxic hypoxia or hypoxemia, the definition is there is a reduction in the partial pressure of arterial oxygen. Anemic hypoxia is a situation where the partial pressure of arterial oxygen is normal, but the amount of hemoglobin that is available to carry oxygen is reduced. So you can imagine it from the name itself. Then stagnant or ischemic hypoxia, oxygen delivery to tissues is inadequate due to a poor circulation in spite of normal partial pressure of arterial oxygen and in spite of hemoglobin being available adequately. So that is stagnant or ischemic hypoxia. So there, the main problem is in oxygen delivery due to a problem in the circulation, okay, heart or the circulatory system. Then histotoxic or cytotoxic hypoxia, the amount of oxygen delivered to a tissue is normal. So therefore, the partial pressure of oxygen is normal in the arteries, the hemoglobin is normal in the arteries, the circulation is normal, but inside the cells, the utilization is abnormal. So those are the 4 types of hypoxia, and we will look at each of these now individually. So let us look at this hypoxic hypoxia or hypoxemia. So there are certain disorders that causes this, and again, as I said earlier, these are divided into 3 categories, like so that it is easier for somebody to study these and learn about this. So the categories are the disorders that cause hypoxemia due to a defect in gas exchange. That is, we also call it gas exchange failure or lung failure. These are the terminology that is given in your textbooks. Okay, so the basically what happens in the first category is there is a defect in gas exchange mechanism. Then the second group is shunts, and here there are we are talking about in this situation where when we talk about disorders causing hypoxemia under this topic, if we use the word shunt, it means a right to left cardiovascular shunt. Okay, not those alveolar shunts. They come under the lungs. So here it refers to cardiovascular right to left shunts. And then the third category would be pump failure, which is ventilatory failure, where the defect is in the respiratory pump, and the main defect is the alveoli are not getting properly ventilated. So you can call this category hypoventilation as well, the third category, right? So let's look at the first category, the defects in gas exchange, which is also called lung or gas exchanging organ failure. So one thing that you already know about is defects in diffusion. So this can be due to the reduced gas exchanging surface area, or it can be due to an increased thickness of the respiratory membrane. And both of these defects are seen in pulmonary fibrosis. And then another big group of disorders or defects that cause gas exchanging organ failure and therefore hypoxic hypoxia is ventilation perfusion imbalance. This group is the commonest cause of hypoxemia that the doctors see in clinical practice. So these are the two extremes. So if you take the top diagram, if it represents the most of the lung, and the bottom diagram also, if it represents the lung as a whole, although it is only one alveolus and capillary that is shown here. The top diagram shows shunted alveoli with perfusion but no ventilation. And as a result, what happens? The ventilation is reduced and the perfusion remains more or less the same. And therefore, the VQ is reduced, the ratio is reduced. And the examples are lung collapse. When the alveoli collapse, the alveoli become like solid structures without any aeration or air entry into those. So it becomes a shunted alveolus. And also in a disease called pneumonia, where there's inflammation of lung tissue, the alveoli are filled with inflammatory fluid and cells, and they become solid, and there is perfusion, but there is no aeration or alveolar ventilation, and therefore it also acts as a shunt. And in the bottom diagram, you can see that the alveolus is ventilated, but it is not perfused. And here, the VQ ratio is increased, and the most classical example would be pulmonary embolism, where the pulmonary arteries are blocked due to maybe a clot or something. Okay, so these are examples of ventilation perfusion imbalance. So you will see that the diagram that you saw in the quiz is about VQ. So the first diagram is an alveolar shunt. Okay, so in disease situations, the alveolar capillary units with shunting will be increased, because you know that even in a normal person, there is a little bit of shunting, but that does not depress the arterial oxygenation. What happens in disease situation is the alveolar capillary units with this abnormality will increase. And in the second diagram, what you see is the alveolar dead space. That is, you have ventilated alveoli, but the perfusion is poor. Again, this type of alveolar capillary units they are scattered in the lungs, but in disease states, the number of these kind of abnormal alveolar capillary units will increase. So those are examples for VQ imbalance causing hypoxemia. So in both health and disease, and in disease to a large extent, you see ventilation perfusion imbalance in the lungs. That is because some areas of the lungs are well ventilated but have a poor blood flow. And also, secondly, some areas have excellent blood flow, but there is no or little ventilation. So In either of these conditions, gas exchange through the respiratory membrane is seriously impaired despite both total blood flow and total ventilation being normal. Okay, the cardiac output would be normal, and in the other alveoli must be compensating for the reduction in the ventilation in the diseased alveoli, but that doesn't count in ventilation perfusion imbalance because in each of these alveolar capillary units, the ventilation has to match the perfusion. There is no point in ventilation and blood flow going in different directions. So in each of these alveolar capillary units, there should be matching. So if that doesn't happen, these VQ imbalance will cause hypoxemia. So this patchy ventilation perfusion imbalance is the most common cause of hypoxic hypoxia in clinical situations. Now we are talking about hypoxia, oxygen. What about carbon dioxide? What happens to carbon dioxide? Carbon dioxide content in arterial blood can also increase during this VQ imbalance if you look at those alveolar capillary units. But what happens is when the moment carbon dioxide increases, that will stimulate respiration, and there would be extra loss of carbon dioxide in these overventilated regions, and this will balance the reduced loss of carbon dioxide in the underventilated area. So as a result, the carbon dioxide level, partial pressure of carbon dioxide level in arterial blood will remain unchanged during VQ imbalance. It will not rise. Right. Now we will look at the second group of these disorders that cause hypoxic hypoxia. This group is called pump or ventilatory failure. So there could be various defects that can cause this, starting from the brainstem down to the muscle. So there can be mechanical defects in the chest wall, like in this person here, there is severe scoliosis, and the thoracic cavity becomes very rigid and non-flexible, and in these people, so therefore the lung volumes and the capacities are low, and that leads to alveolar hypoventilation. And there could be muscle disorders, the intrinsic disorders in muscles, which are called myopathies, or sometimes even if the gas exchanging organ is diseased, when the respiratory muscles work hard for a long time, then there will be muscle fatigue, and the respiratory pump will fail secondary to a gas exchanging defect. Okay, but that doesn't happen in the first instance. It will take some time for the muscle fatigue to set in. And then disorders of skeletal muscle neuromuscular junction, such as myasthenia gravis, causes impairment of muscle contraction, and neuropathies, which affect motor nerves to the respiratory muscles, which will affect again muscle contraction. And then depression or damage to the respiratory controller areas in the brainstem and in other parts of the brain. And also airway obstruction sometimes behaves as a ventilatory failure or a ventilatory defect, because this very high resistance of the airways can lead to a situation where there is alveolar hypoventilation. So these are some of the situations where pump failure occurs. Now, one important thing that you need to remember, students, again, this is a very, very important thing, so that is why I am repeating this again and again. It is only during this type of failure that there will be carbon dioxide accumulation in blood and in tissues. In ventilatory or pump failure, where there is hypoventilation of alveoli. Because if your respiratory pump is normal, if there is a carbon dioxide excess in the body, through regulatory mechanisms, the respiratory pump will work harder and faster, and there will be carbon dioxide elimination. So therefore, it is only during this pump or ventilatory failure that you will see accumulation of carbon dioxide. Right? So this is what I just said. And then the third group would be shunts. A shunt is a situation where blood enters the arterial system from the venous system without going through the ventilated areas in the lungs. Okay. So there are physiological shunts, bronchial veins that drain to the pulmonary veins, and Thebesian veins in the heart that drain straight to the left atrial cavity. So these are physiological shunts. They are present in all of us, and they do not depress the oxygen, partial pressure of oxygen to a greater degree. But if there's a shunt like this, so you see a heart, this is a normal heart, you see the left ventricle and the right ventricle. Sorry. So you can see the left ventricle, and you can see the interventricular septum, and you can see the right ventricle, and there is no connection between the two. So the blood flows are separate, the systemic flow and the pulmonary flow. But here in this situation, there is a defect, which is called the ventricular septal defect. And initially, if a baby is born with this type of defect, the pressure gradient would be from the left side of the heart to the right side of the heart. But with time, if this defect is not corrected, this part, the muscles will hypertrophy of the right ventricle, and the pressure will increase, and the pulmonary pressure will also increase, and the pressure gradient will reverse from right to left, and there will be mixing of deoxygenated blood with the oxygenated blood, and then only hypoxemia will occur in right to left cardiovascular shunts. So now it is interesting to see a shunt like this and its response to inhaled oxygen. So now what happens is, if you give oxygen to an alveolus, 100% oxygen, so oxygen will come and it will into the alveolus, and it will oxygenate the blood that is coming from the right side of the heart, and the blood will be fully oxygenated when it returns to the left side of the heart. Okay. So, but by the time it comes to the end of the capillary, the oxygen dissociation curve here, please remember that this is not the usual curve that you see here. On this axis, you have the oxygen concentration. So therefore, the shape is a little different. So anyway, it is flat, and you can no longer saturate the hemoglobin by giving extra oxygen. Okay. Anyway, saturated hemoglobin does not contribute to the partial pressure also. It is the dissolved oxygen. So by giving a very oxygen at a very high concentration, you can increase the partial pressure, and therefore you can increase the dissolved oxygen. But what happens is, in a shunt, when there's a big shunt, the venous blood or deoxygenated blood enters the already oxygenated blood at a point which is distal to the point of maximum oxygenation. So therefore, however much you give oxygen through the inhalation mode, it is desaturated or in the arterial system when there's a shunt. So therefore, it does not respond, a hypoxic hypoxia in a person with a shunt does not respond well to inhaled 100% oxygen, whereas people who have hypoxic hypoxia due to other reasons, like in gas exchanging failure, maybe in pulmonary fibrosis, they will respond, and the pump failure, they will respond much, much better than this to inhaled oxygen. So there would be a small rise, as I said, in the arterial partial pressure of oxygen because of the oxygen that is added to capillary blood of the ventilated lung when somebody is given inhaled 100% oxygen. But most of this added oxygen is in the dissolved form rather than attached to hemoglobin, because the blood that is perfusing ventilated alveoli is nearly fully saturated by the time the blood traverses the distance of the pulmonary capillary. And again, a shunt usually does not result in a raised PCO2 in blood, because you may have this question, okay, what happens to the PCO2? Because venous blood is rich in carbon dioxide. It does not give rise to a raised PCO2 because of that same mechanism I told you. When the PCO2 rises, that is quickly sensed by the chemoreceptors and the respiratory rate will go up, and therefore PCO2 will come down again. Okay, the reason is that the chemoreceptors sense any elevation of arterial PCO2 and they respond by increasing ventilation. This reduces PCO2 of the unshunted blood until the arterial PCO2 is normal. Okay, so that is the response of a shunt, right to left cardiovascular shunt to 100% inhaled or high concentration inhaled oxygen. Right. Now, the effects of hypoxemia due to reduced PO2, P-simple O2 can be twofold. There are compensatory effects, there are non-compensatory effects. What are the compensatory effects? When there is hypoxemia, the respiratory rate and the tidal volume is increased, and therefore alveolar ventilation is increased. Cardiac output is increased by increasing the heart rate. You will learn about the mechanism of increasing in the heart rate when you do the CVS. But during hypoxia, the heart rate is increased. And when the hypoxia is prolonged, there will be erythropoietin secretion, and there will be increased number of red cells, which leads to polycythemia. And prolonged hypoxemia also will cause cellular changes such as increased 2,3-DPG. And all these are compensatory mechanisms to increase oxygen delivery to tissues. But there are some non-compensatory effects also. One is cyanosis. So this cyanosis is dusky, dark bluish discoloration of tissues due to concentration of reduced or deoxygenated hemoglobin. More than reduced, you can use the word deoxygenated hemoglobin in capillary blood being more than 5 grams per deciliter. So this is cyanosis. I will quickly show a picture of cyanosis. So in real life, even a deoxygenated hemoglobin of 2.5 to 3 grams can give rise to a bluish color, although textbook definition is like this. Okay, but in clinical experience, it has been shown that 2.5 to 3 grams of deoxygenated hemoglobin also can cause cyanosis. So this occurrence of this bluish color due to this deoxygenated hemoglobin depends on 3 things. That is the total amount of hemoglobin in blood, degree of unsaturation of hemoglobin, that is this is related to the partial pressure of oxygen, because the lower the partial pressure, higher the degree of unsaturation, and also the state of capillary circulation, because when the capillary circulation is poor, the blood does not circulate, does not drain properly, and more deoxygenated hemoglobin is stagnated in the peripheries. In the this is particularly seen in hands and feet. So this is the color, dusky bluish color in the lips and the tip of the nose. Okay. And here in the fingertips, you can see the bluish fingertips. There's another abnormality here. The fingers are like they're bulbous. This is called finger clubbing. You don't need to know what that is. But appreciate the bluish color of the fingers. So here the lips are blue. And this cyanosis is easily seen on nail beds, mucous membranes, earlobes, lips, fingers, where the skin is thin. And peripheral cyanosis is seen in instances of impaired local circulation, that is bluish discoloration of fingers and toes. In central cyanosis, there is generalized hypoxemia, and you can see the bluish discoloration not only in the fingers and toes, but also in the mucous membranes, the tongues, and the conjunctivae. Cyanosis is not seen in carbon monoxide poisoning or in histotoxic hypoxia, because carbon monoxide poisoning gives rise to a particular color change in hemoglobin, so therefore cyanosis is not seen. In histotoxic hypoxia, the problem is at the cellular level. So therefore, although there is intense, very severe hypoxia, you don't see cyanosis, okay? And it is more prominent in polycythemic people. It's difficult to see in anemic people and dark-skinned people. And since we are going to do an activity on this in the SGD, I'm not going to talk about this any further. Okay, so the summary of that part is we talked about hypoxic hypoxia or hypoxemia, and we talked about 3 types of abnormal conditions, defects in gas exchange, right to left cardiovascular shunts, and pump failure or ventilatory failure or alveolar hypoventilation. So that section is over. Let's take a small break. Okay, and we will start again with a small quiz. You can take a